Get started. So I think we want to spend the balance of our, or most of our time today making good on a kind of a long-threatened or a long promise to have a discussion of the culture of health metrics, which is the kind of the big new initiative from Robert Wood Johnson. And as we all know, Robert Wood Johnson is the sort of the custodian of the NHSPI for the at this point. So I think we thought it'd be helpful to have a discussion about, first and foremost, how the NHSPI relates to those metrics, but then also perhaps we had hoped that that would launch a broader discussion about how the NHSPI might relate to other metrics. You know, what's its niche, basically? How is it similar to, different from other sets of metrics out there? Before we launch into that, though, Brian, maybe to you, is there anything that you're aware of about the Delphi that we discussed last week, any outstanding issues or anything else sort of regarding the nuts and bolts of the Delphi that you need our feedback on at this point?
Nothing that I could tell you, I'm sorry.
Okay.
I'm sure if Mike were present, he might be able to fill us in more on that.
Okay. Okay. Well, let's then launch into the other discussion. So for those on the phone, I wonder if I'd like to get a sense of whether people have any prior exposure to the culture of health metrics. You know, I've been part of the RAND team, and I've worked on parts of some of the metrics, not all of them. I think I have pretty good visibility into the overall project, and so I can kind of try to fill in the basic thinking behind it and kind of speak to some of the metrics. And by the way, if you haven't already, Brian, check out the attachment that Brian had put in the calendar item a few minutes ago. It was the same attachment that was in the July calendar item, so if you popped it open last month, it may look familiar because it's exactly the same document. But first, I'd just like to get a sense of how familiar folks are with this initiative, just so I kind of have an idea of whether I need to go back to the very beginning or whether I should assume some knowledge. So Jackie, Dominique, Jim, Bob, what do you know about? Have you heard about this much?
This is Jackie, and I reviewed the draft, but I'm not extremely knowledgeable. I don't think you need to go all the way back to the beginning, however.
Okay.
I'm a quick study, and I have looked at it. So.
Okay, great. Anybody else?
This is Bob Burhans. I'm probably about the same boat as Jackie. I'm certainly aware of the broader activity going on in RWJ, and I've looked at these subset of measures that before the call. But it'd be interesting for you to at least describe how these measures fit in with the broader context. I think that would be helpful to me. But other than that, I think I have a good sense of what the activity is and some of the measures that are in it. Okay.
Yeah, this is Jim. I'm pretty close to the same thing. We've used some particular measures. There's some consultants that brought them to the table with us, but other than that, the overall work I'm not that familiar with.
Okay. Okay, well, that's helpful. So, I think that the big picture here, first of all, this is, as I understand it, this is the kind of the new focus for RWJF. That they had a change of leadership a few years ago, and I think my understanding is that they came to a point where they felt like there had been a fair amount of progress in generating improvements in the nation's health, but that they were not satisfied with the pace and came to believe that one of the things that needs to be tackled is to shift from a kind of a cultural understanding in which health is seen as somewhat separate from other parts of our lives and the economy, to a view in which health and well-being issues are seen as really being fundamental to issues of infrastructure, issues of economic policy, so on and so forth. And so I think that's where a lot of this sort of culture of health notion comes from. The idea is to, sort of embed culture or health discussions and well-being discussions in a broader range of venues. And as I said, this is their focus. They think it's something that will take roughly a generation, as I understand it, and they're defining that as roughly 20 years. So I guess a generation as defined by older times when people tended to have kids at an earlier age, I guess. And so a lot of what this is about, I think, is trying to broaden the scope, or they often say broaden the aperture of the health and the health promotion discussion. And so some of the measures, particularly those, and I'll talk briefly about the domains in a minute and where they come from, but the last domain, which is called population health, well-being, and equity, is probably the one that has the most traditionally health-centric measures. There a number of disability-adjusted life years for the top 10 U.S. chronic diseases, average healthcare expenditures. Obviously, it doesn't cover everything, but in my mind, that's a little more sort of familiar territory for health. But I think a big part of this is, as I said, to expand the health discussion, to try to get new people, other people engaged in that discussion, seeing themselves as part of the health and well-being discussion. And so, as I understand it, there's almost a bit of a kind of a logical progression as you move from the first action area to the fourth one. And the first one is making health a shared value. And so really, I think, to me, that this is closest to this notion of the culture of health. And I won't bother trying to go into the specific measures because it sounds like you've reviewed the documents, but the three kind of categories there, I think, speak to this idea. Community health, sense of community, civic engagement. And so I think there's kind of an underlying belief here that there needs to be a shift in thinking as part of this initiative. And please jump in or stop me at any point if you have questions or want to discuss a particular issue. Otherwise, I think I'll just quickly walk through the other action areas here and then stop. So then the second area, and sort of feeding on the notion of expanding the conversation, really focuses on this notion of cross-sector collaboration. And we, in this project, in the NHSPI project, have discussed one or two of the measures in this area. Or actually one of them, the number of high-quality partnerships, the one that focuses on collaborations between health departments and other partners. And so I think the belief is that you not only need to change people's mindsets about health and get them to think about health and well-being in new areas, but you need to get new people into the conversation. You need to forge new discussions among people who don't normally talk to each other. And so that's what this action area and these measures are about. And then moving to the third one, this is starting to get a little more into familiar territory. This is where there are measures of the built environment, which I think by now many of us are very used to hearing about and thinking about. But I think they also wanted to press on that notion of environment as it relates to health, to include social environment. And so there's a measure on access to public libraries and things of that nature. Economic environment. So there's there's a bit of an emphasis on segregation and things of that nature, and also policy environment. So policy and governance. So a couple of the measures have to do with uptake of complete streets policies, indoor air quality laws, things of that nature. Then the fourth action area, as I said before, this is the one that I think probably will look the most familiar to people who are used to thinking about health. But even here, I think there was an attempt, and I have to say I did not work in this particular action area, so I can't speak to it with a lot of expertise, but I think there was a real attempt to pick measures that had to do with healthcare, but that focused more on partnerships with someone other than the usual suspects. And so, there's a measure of access to dental care, for instance. There's also, a CAPS measure that gets at consumer satisfaction, and I think the idea there is seeing the patient as kind of an active part of providing care. So again, I think the idea is to broaden this conversation to bring in a broader set of discussants. So the measures really, I think, reflect that. Just one or two other quick points. Unlike the NHSPI, this is not intended to work as an index. So there are 41 measures. There were going to be 40, and then somebody added one at the last minute, as I recall. But there was never any plan that I recall to roll this up into a single number. The phrase that I hear kicked around is that these measures should be conversation starters or points of entry into a conversation. And again, no thought as far as I'm aware of rolling these things up into a single index. So I'm going to stop there. I'm sure there are other things I could say, but let me stop there and see if folks have thoughts or reactions or questions about the kind of the big picture behind these 41 metrics in the table.
They're really what we've been working with across our population health. Now, we also roll human services into our big department, along with healthcare, EMS, trauma. So the scope is good. I'm not sure how it relates to preparedness index, other than certainly thought-provoking, and the partnership piece for healthcare is very critical, and a lot of that's being done at the Healthcare Coalition level. And I'm not sure we have a measure for partnerships yet, unless Bob knows.
Well, this is what would have been helpful, Chris, is this is a really good chart, but I would have probably added an additional column that would have said what it means to the intersection of the culture of health and health emergency preparedness, because I think that's or health security. I think these are as Jackie said, I think these are great measures to if you're trying to evaluate a shared culture of health. But then how do we take the culture of health and how do we take it to the next step, which is which one of these 41 or which set of these 41 is important to health security preparedness, and how do we translate that to the index? I think that's the challenge, and I think that's where we need to put our work.
Yeah, I agree, and I think that's where I'm hoping that the group can have some discussion today. Obviously we're not going to be able to build that table on the phone here, but I for one, and I suspect the UK people would agree with this, would find it helpful to have kind of a more general, almost a conceptual level discussion about that issue. Where are the overlaps? There is a big focus on community resilience in the National Health Security Strategy in the NHSPI. We've been talking about and sort of struggling with this issue of how to incorporate prior community status into the NHSPI. A lot of these culture of health measures, clearly there's some intersection there. But on the other hand, I think what we're saying already is that, you know, it doesn't seem like NHSPI ought to cover all of these things. So where is the overlap in those in the Venn diagrams? And then back to a question that I posed at the very beginning, which is, well, what is the unique niche that NHSPI is trying to fill with respect to at least this index, and maybe more generally with respect to kind of the broader population health discussion that Linda referenced. So I guess I'm going to throw the question right back out to the group. I think it's a great one.
Well, this is Jim. I think a big part of what you addressed just now is the part that we need to explore, because I think part of the niche is how resilient communities are, so that they can respond properly and that they can recover appropriately and quickly. So there are probably a number of these measures that can help describe that resiliency piece, maybe as well, if not better than anything that we've looked at thus far. It's just the devil in the details of trying to get that balance into what we're looking at.
Mm-hmm. Well, I guess, you know, one thing I struggle with a lot, I think, is, you know, I think it's all well and good to frame the NHSPI and NHSS and other things in terms of community resilience. But on the other hand, I think an outsider might listen to some of our conversations and say, all right, well, are you telling me that we basically need to fix poverty and fix society in order to be prepared for disasters, or, you know, to be ready to recover for them? And so I think that, you know, it is this issue of what is the scope? You know, what parts of this are relevant to NHSPI, are relevant to the national health security conversation, and where are the other parts where, well, there's a relationship, there ought to be an interchange of ideas, but it's, you know, it's not a part of the national health security enterprise, at least directly. So I think part of our challenge, as I understand it, is to start thinking about how to define those boundaries.
Yeah, so, you know, when I look at some of the social economic pieces for, you know, mortgage, you know, percentage mortgage, people are spending all their money on mortgage, and housing, affordable housing, et cetera. I think that we're getting too deep into the community.
Mm-hmm.
We almost have to back a little bit farther out when we're talking about overarching community resilience. If we dive in too deep, we're going to get, I think, mired down into trying to find our way and relating it back to the index.
Mm-hmm.
And, you know, some of the, I mean, it's really important, and as public health or population health, it's very important. But I'm not sure for what we're trying to accomplish that it will inform us or help as we go, you know, look at it across the nation.
Kind of reminds me, I remember reading an anecdote, somebody, it was a root cause analysis of the Chernobyl nuclear disaster in the former Soviet Union, and they interviewed one of the chief engineers who designed it, and you know, they were trying to kind of get him to speak to root causes, and he said, well, in some ways it was the revolution of 1917. It all goes back to, you know, the basic political structure of society. So, all right, well, fine. You know, what do you do with that? So my understanding is that you know, we're not going to, we don't have the opportunity to add any of these measures or any similar measures, I don't think, into next year's version of the index. So I think we're as I understand it, and Brian, correct me if I'm wrong, from the UK perspective, I think what we're doing here is sort of laying the ground for thinking about how to expand the next version of the index. So you know, I think it might be helpful to kind of get down to specific measures, but I think the more important thing is to kind of try to lay out what are the principles that kind of allow us to say what's relevant to national health security and what is maybe just a little bit too far afield.
Yeah,
So, Linda, if I can throw it back to you, do you have any ideas to throw on the table about how we might make that decision?
One of the things that strikes me is when I look at these, and I I guess my thinking is evolving because I haven't had a chance to go through them and to see if my categorization or my taxonomy would work. But it almost seems as if there's some, they're all drivers, right? But it'd be very interesting to take a look at which ones are truly measures of pre-event community status, and they basically describe the attributes of a community across a series of things that affect health. But it'd be very interesting to take a look at those same pre-event community status measures and see to what degree they would have a influence on resilience and an influence on health security preparedness. I happen to be working on another project with John Links from Johns Hopkins on a systems dynamic model for community resilience.
Mm-hmm.
And pre-event community status is used, the measures are used to kind of set, the y-axis bar as to where the community functioning was, so that when a disaster hits and you have a degradation of that status and then it bottoms out and you have a recovery curve, how, the pre-event community status is used to measure the 2 points on the curve is where it started, and then after response and recovery, how long it took to get back up to that level of pre-event community status. But it's kind of a unique way to look at it, not so much that the pre-event community status influences the response and recovery, but that it's the marker of what the level of functioning was in the community before the event happened. And I think it'd be interesting to try to take a look at these to see which ones are and by the way, I think most of these are really good measures of pre-event community status. But which one of those are really going to affect health security preparedness and are really going to affect resilience? In other words, we can tie them with either through an evidence base or in the absence of evidence with face validity that they're going to influence the that curve that we're looking at to get back to the original level of preparedness. So I think, again, it'd be interesting to go through these and see which ones do or don't. And again, I agree with you. I don't think they're going to influence us this year, but the whole issue of how we want to incorporate pre-event community status into the index, I think, needs to be something that we need to have a robust discussion, and I think with both of the work groups, as well as going back to the National Advisory Group as well, and taking a look and getting their input as well, because I think this is going to be one of the key things we need to do is being able to tie this to the culture of health, and I think we have to do it in a way that makes sense not only scientifically but also makes sense to the broad array of people out there that are work preparedness, whether it be emergency managers or public health preparedness director or hospital directors.
So I've got window washers outside my window here making a lot of noise. I'm trying to stay on mute as much as possible, but I'll try to get a question in here or a response. So Bob, or anybody else at a general level, even at the level of these 4 action areas, do some of these feel intuitively more on track than others? So, for instance, my initial reaction is, all right, the cross-sector collaboration, to me, I think I can tell some pretty good stories about how that's related to response and recovery, just because so much about response and recovery, well, and preparedness for that matter, is about partnerships and interactions. I always think back to Eric Heider had a nice definition of a disaster as something along the lines of a situation where people who don't normally work together have to work together doing things that they don't normally do. It's kind of an organizational perspective on preparedness and response. So my prior is that the cross-sector collaboration one seems pretty ripe and pretty directly related. On the other hand, maybe not so much the first action area. the making health a shared value, but I don't know. I think I could tell a story, but I just feel like the story would be longer and more involved and involve more steps. So I don't know if that observation helps spur any better thinking.
Yeah, I think we're all struggling a little bit. Pretty clear.
I'll tell you, just from a process standpoint, when you have to sit down and answer what the rationale for the measure is, how to interpret the measure, and how it affects health security preparedness, that exercise very much, some of the narratives are, you read it and it just makes sense to you. Other narratives, you realize that the narrative is a stretch and someone's trying to tie it to health security preparedness, but it probably does not have a significant impact. So, some of this may literally be processed. We need to go through them and actually have that discussion and get a sense of which ones work and which ones don't.
Well, I don't think we have time to get through all 41 in the next 29 minutes, but we could take just a few of these and sort of test a process. Would it make sense to maybe pick one of these action areas and just kind of get down to specifics? See how that goes?
Sure, why not?
Anybody want to nominate one of these 4 areas?
Well, I think cross-sector collaboration is a great one to start with.
I agree.
Okay, let's give it a try and see what happens. So, I guess I have the page open here. We could go through them top to bottom, but maybe let's just kind of scan them, and when somebody notices one that catches their eye, call it out, and let's talk it through. I think the first one, and that I think is the one that we have made some, had some specific discussions about including into the NHSPI, the number of high-quality partnerships between local public health and other partners. That one again, you can't get too far in a preparedness plan or in an introductory course on preparedness and response without grasping the importance of partnerships. So to me, that one is fairly self-evident. What do others think?
Yeah, that one's given.
Yep.
So the as you go down to the percentage of full-time sworn personnel who have served as community policing or community relations officers. So are you thinking about the VIPS program under the Citizen Corps? I mean, that's a number that's out there. And that the whole Citizen Corps program and that volunteer initiative kind of speaks to that. The community policing, I think, is interesting because that's probably not even allowed in some jurisdictions. But isn't that really speaking to volunteerism rather than just policing?
I didn't work on the details of this measure, so I'd have to go back and do a little quick checking. There are other measures of volunteerism in the first action area, and so I think my sense is this has more to do directly with community policing than with volunteerism. But again, I guess at this point, I think maybe the issue for us is this issue. Well, I guess you could take either one, either volunteerism or the community policing aspect, and ask, is there a story that links that with national health security?
Right. I don't know that we've looked at the number of law enforcement per population or per communities or how that impacts emergency preparedness, or have we looked at that, Bob, at all?
I don't think we have looked at that at all. I mean, I'll tell you, I look at this one, And I just know, community policing has been demonstrated to have some very positive effects outside of the reduction in crime, but also, in other areas in neighborhoods. And the only reason I know that is because I have a friend who basically, the state police, that basically lectures on those issues to local police departments in the state, and I've sat in on a couple of his presentations. But I don't think the current index, I don't think we've looked at those as a reflection of health emergency preparedness. No.
It came up, I was involved in the CDC pod standards many moons ago, and, so that when you're talking about pods and pod security, that's one very sort of concrete place where that comes up, but I'm not aware of any other discussions.
Yeah.
It strikes me that, there are a couple of ways in which it could be relevant. One is areas where active coordination with law enforcement is very critical, and pods is probably just one example of that. Boston, the bombing is kind of an interesting example of collaboration between police and health, both on the scene, dealing with providing acute health care, and then during the lockdown and the days after. So I think you can find some specific stories that relate it. Beyond that, I guess, it might possibly be, kind of a measure of community trust, which, I think gets more to kind of more general concepts of resilience.
Well, in any incident, whether it's response or recovery, unless you are working with law enforcement, you can't even get access. Bob can probably tell you some stories. And I think it's important.
Yeah, for whatever reason, they let doctors through, but they wouldn't let nurses through. And
Correct.
We needed the nurses worse than we needed the doctors. So.
Right. So, I think it's something we could discuss in the future, kind of, if there's any data that we can use to support. At some point in Michigan, emergency management is with the state police, so I tend to think law enforcement a lot. So I may be skewed a little bit. So you can toss me the baby out with the bathwater in this case if it doesn't really flow with what we're looking at.
So Chris, do you know on resource investment across sectors, the annual dollar of federal appropriation is to select health initiatives? Do you know if health emergency preparedness is one of those initiatives?
I've got a lot of noise right now. I think I heard that. I don't happen to know the answer to that specific question.
Okay.
I didn't work on this set of metrics, unfortunately.
Well, I think the one that addresses the annual percent of states with climate action plans is probably one that, beyond just the politics of that in a number of the states, would indicate some level of preparedness and health security. So that one might be a good one to think about.
I agree with you, Jim.
Yeah. Linda, what do you think about that one? Any others that kind of jump out? Bob, to what extent does the kind of the climate resilience piece come up in the John Link's work that you're doing? Are you at liberty to say?
I think it's we have something which is the built environment, and we're looking at the built environment's vulnerability to the effects of climate change, but nothing specific about whether you got the other thing is you have to remember is the Hopewell project. It goes down to the county level, and so when you're thinking some strategic policies, they're more often at the state level, working with the county. So not every county might have a climate plan, but The state may have one that the counties are participating in, so it just gets down to, how granular the data is and whether it's appropriate to look at that. I mean, certainly, the parishes in Louisiana have climate plans, climate action plans, and I think some of the in low-lying counties. But I think that may be one where the state level maybe a more appropriate measure. But I think we're looking at built environment and in terms of mitigation and issues associated with climate action plans, but not necessarily a strategic plan for the entire state.
So let me ask a kind of a different question. Again, just focusing on cross-sector collaboration, which one or ones seem the least related to national health security? Again, I'm still trying to kind of figure out how we're going to proceed on this, but what just seems the least related and why?
Well, I think the annual measure to children's exposure to TV for unhealthy and healthy foods and beverages.
Yep.
I don't even know how that comes close.
Yeah, I was thinking the same thing. I think for the culture of health, it's seen more as an indicator of the extent to which the advertising industry is on board with health promotion.
I'd say they're not.
Right. And I think that's what the data are going to show when they release this metric.
Right.
And that may be part of the dotted line of division, if you will, would be, health promotion is maybe a little bit too far to one side. Those indicators that are related, really kind of in this particular grouping, there are a number of them that look at the overall health and why you could tie that to resiliency, promoting that health. I don't know if that's so much of the health security piece as we would imagine to be part of the index.
Okay, so just so I'm clear here, you're saying that measures of prior health status might be relevant or might be fair game for national health security, but measures of efforts to improve or promote prior health status are not? Is that where you're suggesting we might draw the line?
Well, I think it's kind of a dotted line. There may be some that could be tied to health security, but I think, right, like tobacco-free zone, I was one of the other ones that popped up a while ago. While, I'm in public health, so that is important. I don't know that that's important to health security.
Mm-hmm. Any other thoughts on that? I mean, this I think is the first attempt to kind of articulate a principle. So, Bob, Jackie, what do you think?
Yeah. So the other piece, I think, is when we're talking about families that are, I think it's getting to social economic, when you talk about families that are eligible for FMLA or for insurance or have medical insurance, that's access, that's available access to care, but it does not tell us about their health status or the resilience, I believe, anyway.
Uh-huh.
And I'm not sure we want to go there at all.
Okay.
The percent immunized, we've gone to that level. There's other health pieces. Dental care, I think, is important. But once we get into FMLA and types of insurance and, whether they're watching cartoons that market Twinkies or apples, I'm not sure that we can go there either. So it's pretty tough to draw that line. I think I just keep saying that.
Well, I feel like we're making some progress here. It seems that we're focusing on the prior health status as one of the kind of the key areas. We also seem to be focusing on some of the partnership issues as pretty critical. because partnerships are very much on the critical path to everything that we talk about: preparedness, response, recovery.
Well, it's like you take one of the ones that y'all have for built environment and physical conditions. It looks at healthy foods. The availability for a community to feed itself is obviously an important characteristic of resiliency. Whether or not percentage of the population eats that food every day, could go to the core of, are the people healthier, so are they more resilient? But I think that's a harder indicator to drive to than, can what ways can the community mitigate any type of health impacts that might come. So I think some of them have the tenets of what could be part of the process. I just don't know that they're exactly put together for the security model.
Okay, we're starting to run out of time here. Maybe let's kind of pop back up and think about what's the best way to proceed. I feel like we've kind of articulated at least some provisional principles. Focus on prior health status, not so much on efforts to improve that status, but more direct measures of what that status is. Partnerships seem to be fair game, and we haven't looked at all the measures, but what are your thoughts about the way to kind of take this to the next level? Bob, I think you started the conversation by saying that we need to eventually kind of get to another row on the table that kind of documents relevance to national health security for each of these measures, and I feel like we're making some progress. Do we go right there, or is there another step?
Well, I think that's probably the next step, and that probably is going to need some input, at least from some subject matter experts. But I think that would be the way to go. I think we understand why it's relevant to the culture of health. Now, is it also simultaneously relevant to health security preparedness? And I think, that's, and it needs to be done in a systematic way.
So we don't know, we don't have evidence that the culture of health equals community resilience, right? We
Absolutely
know
not.
Resilience
Right.
With health security. So if we did a mathematical formula on that, it wouldn't necessarily mean culture of health equals emergency preparedness or health security. So there's a middle road. If we can say the pieces of culture of health relate to community resilience, if the individual does not participate in the community for this measure, then it does not equal community resilience. So how do you measure that, and where's the science behind it? So we need some sort of science to get that leap of faith.
Yeah, I think that's a good way to put it. Okay, well, I guess I'm sensing that there is a homework assignment for the program office here, and I think I'm going to try to reach out to some of my RAND colleagues who work more directly on resilience, and some of them have also worked on the Culture of Health project, so I can try to get their thoughts on where the science is and where the science is just lacking, and I suspect others will have ideas as well.
Great.
So, yeah, I guess I'll talk to Brian and Glenn and others as well. But I'm thinking maybe we could produce a kind of a starter draft of this another version with that extra column, and then I expect we can get some feedback on that. And out of that discussion, I expect we may, kind of sharpen our thinking about what the overall big picture story is. I'm just imagining somebody standing up and having to justify in a few minutes why, why these new measures and why not other measures. And so I'm hoping that we can work towards kind of a good short answer to that question. What's relevant to national health security and what's not. I'm so sorry about the noise back here. They've been, it's a big building and they picked this very moment to come to my window here. So is there anything else that anybody wants to raise? Otherwise, I expect we'll be taking this issue up again in the future. And, I think, and again, culture of health is not the only other set of measures that we need to think about. But I guess in my mind, it's the one that might potentially kind of press the thinking, press the conversation more than the others. And so I figured starting here would kind of make sense. And then we can go back and revisit some of the other indices as we move forward. So any other issues that anyone wants to raise?
No, I think this is excellent. I mean, we have to evaluate this, so it's important.
Okay.
No,
Bob, Jim?
Well, it's Jim. I appreciate the work that's already been done, but I do think adding that additional column to see how they tie together is good, and just something to think about, not necessarily a homework assignment, but something to think about as they're doing that work. A lot of the questions and feedback that I get on the index are related to, okay, so now we know and we have these measures and we need to plan some ways to influence some of that process, not the process of creating the index, but the actual measures. If there's a way that we can think about for the explanation, not just how it ties to health security, but how it can actually be manipulated or how it can be influenced?
Right, yep. Yeah, and I guess I forgot to mention that was a filter that the RWJ people tried to apply to these metrics. So for each of these, could you imagine some sort of action that people would take? And, so I think there's other documentation that I can look back to or that we can look back to in order to kind of elaborate some of the thinking on that.
Well, I know the couple that we've employed here, they had some of that piece in there, and I didn't know how readily available that would be, but I think it would help in part of the discussion.
Mm-hmm. Okay. Bob, any closing thoughts?
No, I think that it's something, as Jackie said, we have to do, and I think it's important to get it done, and I'm glad we're starting it.
Very good. Brian, anything else from the UK side?
No, thank you.
Okay, and perfect timing. The window washers are now moving on, so they timed it perfectly. So sorry about the noise, and we'll talk next month.
All right, thank you.
Okay, bye.
Bye.
Bye.